Hello, everyone. Welcome to another virtual morning report. Really excited to be co-discussing with Andrew. Andrew and I co-discussed in person a few weeks ago, or maybe months at this point, and excited to discuss with you again. Andrew, how are you doing?
Yeah, good to be back and happy to see I'd say a pretty good turnout for I don't know how many people are on the East Coast here, but welcome to people from all over. And we have a case coming from North Carolina today. And our case discussant, do you want to introduce yourself?
Yes. Hello, everybody. My name is Azeh Burhani. I am an IMG from Ethiopia, and I'm currently doing research here at in North Carolina at the University of North Carolina, Chapel Hill. Um, I'm pretty new to clinical problem solvers. This is my first case, so I'm excited to be here and share this case.
Thank you, Isaac. I'm very, very excited for the case. Andrew just assumed it's from North Carolina. It could be from Ethiopia, so we don't know. It's a mystery case.
It's
Yeah.
actually from North Carolina,
Don't
so
tell us. Don't tell us.
oh, oops, sorry.
Yeah, no, you're good. Kritika, are you able to say a word or unmute to just like introduce yourself since you're helping us with the teaching points today?
Hello, everyone. I hope all is fine. Happy to be doing these teaching points today.
Thank you so much. And VJ was able to join, but I know he was having connectivity issues. So VJ, if it's not working, it's okay. Like we can, I can share the screen if you want, if that makes it better as well. So it causes less strain on your internet connection. All right. So, Azib, whenever you're ready, you can get started and let's get to the case.
Okay, all right. So I'll start with the first aliquot, with the chief complaint. This is was a 58-year-old maid who presented to the ED with worsening headache of 6 months duration. Do you want to, should I continue with the HPI or do you want to discuss on the chief complaint?
We can discuss here. I don't know, Andrew, if you want to take it. I know you have a good approach to headache.
Yeah. I haven't seen a headache case presenting in the ED in a while, but we have a mnemonic we use to basically screen for sinister life-threatening causes of headache in the CP solvers called the Snoop mnemonic. That's pretty good. So if I recall correctly, S stands for systemic symptoms. So basically what we're doing in approaching a case in an urgent care clinic or the ED is we're screening for these things to see if they need further workup for something life-threatening. So that's what we're going to be asking for in terms of getting the history in the HPI. So the first question for the patient would be, do they have systemic symptoms? Like, have they been having fevers? Have they been having chills, night sweats, rigors, any sort of systemic signature of disease? And I believe is for neurologic symptoms like focal neurodeficits. I'm having a hard time recalling. Maybe Youssef, you can help me out. And P, I remember is positional, which basically is a signal for high intracranial pressure where the headache gets worse when you lie flat and more of the CSF is basically rushing to the brain. So if you have high pressure inside of the skull, then the headache gets worse. Onset greater than 50 is O, Youssef. That's it. So this guy automatically wait, was it 58 or 78? I thought I heard 50 something. I'm seeing 70 something. But just clarifying is of they're 50 something years old, is that right?
58.
Oh, 58.
58-year-old
Okay. Yeah,
maid.
58. So even at the age of 58, so even though they're much younger than written here, that's still actually a red flag for someone who's never had a headache in their life because generally the primary headache syndromes they begin to come on before the age of 50. So if someone's before age of 50 and has migraines before and they're representing with a migraine, it's much more uh, reassuring than someone over the age of 50 who's never had a headache before coming in with something. So that's something we would be asking the HPI. Has this person had headaches before, like this, before the age of 50? I don't recall if duration is a red flag. I'll just pass it off to Youssef, but those are kind of the first sorts of screening questions you'd be asking a patient like this, just to answer the question, do you need to put more cognitive energy into this versus is this just a primary headache syndrome like migraine, tension headache, or cluster headache?
Yeah, I agree, Andrew. It's like the question is this a primary headache or is it a secondary headache syndrome? And headache is so common that often it's not the center of attention of a case. And patients somaticize it and attribute it to different things, like they attribute it to like blood pressure or meds, and they don't realize that in itself could be like an issue. And I think here we'll be like screening for clues on the history and exam to try to find like which direction we're headed. And to see what tools we're going to use in the next few aliquots, because like in general neurology you don't have a lot of tools. It's only like CT, MRI, LP, biopsy. If you think about it, it's just 4 options. So it's pretty fun to see which of these tools we're going to use and see if there's any systemic symptoms. So Asa, back to you.
All right, thank you. So this is the patient is a type 2 diabetic with associated neuropathy and hypertension. The hemoglobin A1C was presented 9.1%. So the headache started 6 months prior to this presentation. Initially, it was left-sided headache with double vision on the left side as well, and associated with intermittent vertigo with turning of the head. And progressively, the headache became all over, was going down both the ears and eyes. He no longer had double vision, but he was getting dizzy when he was looking up or down for too long. And he was having issues crossing the roads because of the left eye. And he also had nausea associated with the headache and light sensitivity. He was seen at outpatient by neurology. CT was unremarkable, and he was started on Imitrex for the migraines. But he did have some improvement with the treatment, but he was still having the headaches. He had mild tenderness in the left greater occipital groove and the left temporal artery. So neurology started him on verapamil and Ubrelvy, and they ordered ESR to work up for temporal arteritis. At the same time, he was experiencing dysphagia to foods and pills, throat swelling, nausea, fatigue, and weight loss. For this, he was seen by general surgery. They did an EGD with esophageal dilation. They also did colonoscopy, which was normal. And he also was seen by ENT for otitis externa. He was having ongoing drainage from the left ear from a recent episode of otitis externa, and he was started on cefdinir. So all of this was 6 months prior to the current presentation. And then 6 weeks prior to the presentation, he again presented to the ED with left facial droop and difficulty closing the left eye. So they planned for a temporal artery biopsy and started him on high-dose prednisone. So I'll stop there.
Wow, Asa, what an aliquot. And Andrew, if you want, I'm gonna start with the initial presentation, which is the diplopia and some of the symptoms, and then maybe you can take the systemic findings like the dysphagia and the otitis externa and see how you can like combine the two. So in the first part of the aliquot, we hear that the patient had double vision. And usually whenever you hear about double vision, you quickly want to stratify it into, is this monocular or is this binocular? So the question is, are the eyes misaligned, or is there an issue in the optic tract between the eyes and the brain that's causing the vision for the person to have double vision? And the way you can test for this is that you ask the patient to close one eye and see if the diplopia goes away. And then if the diplopia goes away, that means they're just misaligned. If it doesn't go away, that means that they have monocular diplopia, which means there's an issue with the optic tracts. And usually, if it's along the line of the optic tracts, it's an ophthalmologic complaint or a problem. But if it's diplopia that's binocular, or if there's any issue with like misalignment, then usually it's like in the neuro realm. And here there are many clues as to why it's binocular or why it's just an issue with misalignment. One of them is that it's more to the left from what I heard, is like they're having issues with the left more than the right. That's one. And two, we hear that there's other cranial nerves that are involved. We hear later about there's like a facial droop, maybe some temporal symptoms, and maybe that will tell us that it's actually more likely to be a droop on one nerve causing a misalignment. And usually when there is a misalignment, the next question is which nerve is involved causing the misalignment? And that's where I always have to look it up. But the way I try to remember the nerves is the nerve number 6 is the abducens, usually looks laterally, cranial nerve 3 as well, cranial nerve 2 as well. These are like the major nerves that cause the ocular movements. And the question is, where along the track is the nerve affected? So is it in the eye? So you can go along the entire pathway. So you can see, is it the muscle? Is it the muscles of the eye that are affected? Is it the junction? Or is it the nerve? And depending on where on the track, should try to localize it based on the clues. And then if you want, Andrew, you can start talking about the dysphagia and the otitis, and then maybe I'll loop in the idea of temporal arteritis, and then we'll co-discuss together.
Yeah, sounds good. I had some thoughts on the temporal arteritis too. I'm not a neurologist, but when you start seeing things line up with the cranial nerves, diplopia, as Yusuf just beautifully outlined, which is very likely going to be something on the neuraxis here, as Yusuf just said. Dysphagia, another function of the cranial nerves, potentially. Facial droop, that's really all pointing to the brainstem for a non-neurologist. And what are we looking for on a CT? So when this patient went to see the neurologist in the clinic, they got a CT. The CT is really to look for large mass lesions and also hydrocephalus and kind of complications of high intracranial pressure, like brain herniation. It's not going to catch things like small strategic ischemic strokes or small mass lesions. And when we're inherently talking about the brainstem, we are talking about like a pretty small space. So there could be some sort of either stroke or small strategic mass lesion in the brainstem that's kind of causing all of these things. Vertigo is another interesting thing. There's double vision and there's vertigo. We have to be careful with how we interpret what patients are telling us in terms of dizziness. Like this patient may not have true vertigo, meaning it's of neurologic origin dizziness. But when we're seeing all of these other cranial nerve signs line up like this in the brainstem, then it does make it very tempting to want to call the extreme nausea the patient was experiencing and the issues crossing the road really vertigo. When they were looking somewhere, they just started having the room spin sort of deal. Another two random thoughts on the throat swelling and the like throat swelling. So for the otitis externa, very common. So it's very prone to say that's unrelated and just incidental in a 58-year-old. I've had that before. And then for the throat swelling, we have to check ourselves sometimes and make sure when we're talking about headache, things are not outside of the brain affecting the brain. So I was thinking for a second, oh, is this someone with like what do you call it, oropharyngeal abscess in the back that's kind of radiating to the head and causing headache. But then you go down your list here and we talk about all the cranial nerve dysfunction. And you're like, that hypothesis is pretty hard to sync together. You can have sensation of like throat swelling, I think, with oropharyngeal dysphagia too, just like on the initial phase of the swallow, just a sensation of having a hard time really getting that food bolus down in the initial phase, really marking oropharyngeal dysphagia. So when we say, okay, that's a function of the cranial nerves, and we're just back at square one. So I would say very focused on the brainstem right now. And then my brief comment before passing it back to Youssef on the idea of temporal arteritis. Temporal arteritis can certainly cause chronic headache. In patients less than 50, it's extremely uncommon and essentially ruled out, but the patient does screen in for this. A negative ESR has a pretty high negative predictive value. It's not perfect. So if your pretest probability is on the higher side and the ESR is negative, it doesn't rule it out. But if your pretest probability for it is on the lower side and the ESR is negative, then you can really rule out temporal arteritis. I would say headache, certainly very common. That story fits here. But the double vision and all of these neuro deficits, GCA can cause posterior circulation strokes. It's very, very, very rare, actually. So I would say it's less common in this patient. Probably a negative ESR rules it out. So we'll see how that ends up playing out. And yeah, Youssef, I'm curious what thoughts you had on the GCA.
Yeah, so as you said, GCA has to present after the age of 50. And the question is what test is like sensitive for it? And there's not a lot of tests. And the issue is that even the tests that we have don't have a high likelihood ratio. So for example, tenderness to palpation doesn't have a high likelihood ratio. Having jaw claudication has a like maybe likelihood ratio of like 4 almost, but then everything else is less than that. So there's very few tests that you can do right off the bat that tell you, oh, this is probably going to be GCA. So it's very hard. It's one of those diagnoses that needs either a duplex ultrasound in a someone who is specialized, or a PET scan or a biopsy to like rule in. And I was also going to consider the dysphagia. It's also very interesting that the patient having dysphagia, and when we think of dysphagia, you want to break it up into is it oropharyngeal or esophageal? And then when you go to esophageal, you want to think, is it structural, or is it something related to the tone of the muscle, or the movement of the esophageal muscle? And the first step is the board answer is getting an EGD first. So in this case, the patient did get an EGD, and we didn't see any mass lesions, which is good. Sometimes you want to get a CT scan of the chest to rule out there's no like external compression. But then once you get, after you rule out like a mass lesion, that's where it gets interesting. Is it something related to the muscle? For example, multiple myopathies present with dysphagia, including like inclusion body myositis, even any like polymyositis can present with dysphagia as well. Is it the nerve itself, like Andrew was alluding to, that could this be like a nerve, like an ALS syndrome affecting the brainstem and causing this patient to have dysphagia? Or is it the nerve in between? And I do use the rule of 4s for the brainstem. Did you ever use that, Andrew?
Yeah,
Yeah, he did.
totally.
So like,
Yeah, love that
yeah.
role.
Yeah, it's like every 4 cranial nerves are in part of the brainstem, and the multiples of 3 and 4 are in the medial portion, while the rest are in the lateral portion. So 3 and 4 are medial in the top part of the brainstem, and then 6 is in the medial part, and then 12 as well, if I remember correctly. So I'm really curious what's gonna happen next. I think on my bucket list is seeing to see if there's any improvement with the steroids, to getting imaging of the head. We already got a CT scan, which is pretty good, and I think we want to get some form of MRI or MRA. I think that will be good to see, is there like a leptomeningeal disease? Is there like a subtle stroke like Andrew alluded to, or something like that? So that's on my wish list. Anything else on your wish list, Andrew, other than a physical exam?
No, that sounds perfect.
Back to you, Isabel. What an amazing case so far.
Uh, Very great discussion. So when I continue to the past medical history, he had a history of recurrent otitis externa. And 1 year back, he had bilateral otitis externa. It was treated with Ciprodex and augmentin. But despite that treatment, he was still having left ear pain and left tympanic membrane perforation. So he had another round of Ciprodex, and they did culture, and it was positive for fungal, and he was started on diflucan. And then months later, he was seen for intermittent left ear pain again. This time there was a lot of debris in the left canal, and he took another round of Ciprodex. And then for other social history, he works in a sawmill. And other than that, there's nothing significant. So on presentation at the ED, vital signs were within the normal range. Temperature was 37.2, blood pressure 132/82, heart rate was 78, respiratory rate was 18, and saturation was 92 on room air. The pupils were reactive bilaterally, and external ocular muscle Movement was intact, but he did have tearing from the left eye and difficulty closing the left eye. There was also tenderness on the left maxillary sinus and then the left external ear. There was also narrowing of the external ear, dried green discharge on the left side, but otherwise the tympanic membrane was clear and there was no mastoid tenderness. On the neck, he had bilateral tenderness around the trapezius muscle, more on the cervical spine, but not on the midline. On neural exam, he had left facial droop, dizziness with turning of the head, but no nystagmus. Speech and language was normal. And on the lab workup, CBC was 10.9 with a neutrophil of 89%. Hemoglobin was 10.7, platelets 217. BMP sodium was 136, potassium 4.4. BUN was 15, creatinine 1.05, glucose of 219, and calcium of 9.9. And I'll stop right there.
Wow, what a good presentation, Azim. I'm so happy you came here. Yeah, I think this aliquot just goes to show how context is really important. Remember how I said the otitis externa is probably incidental? Well, Youssef, what do you think? Are you thinking the otitis externa is incidental now? I'm thinking probably not at this point.
Yeah, probably not, right?
Yeah. Those are a lot of ear infections. So when you see that the timing of that is like a year prior to the onset of the headaches, that hypothesis of something outside of the brain making kind of its way into the CNS definitely becomes more interesting. So um, this patient has uncontrolled diabetes. That probably is what put them at risk of these infections. The A1C, I believe, was close to 10%. So I pulled up my immunocompromised notes, which was actually from a session that Yusuf's friend at Emory gave. And I'll just remind ourselves that if you have very bad uncontrolled diabetes, it's basically a neutrophil defect. Your neutrophils don't work as well as they should. So that puts you at risk of basically exogenous organisms that you normally phagocytose. So normal flora, bacteria, and fungus, as in Canada in this case, and mucor, as Debbie just put in the chat, you're basically at risk for. So that was the setup for this, I think. And now we need to kind of talk about the complications and what that would look like. So basically what we're saying, if the patient has multiple cranial nerve deficits and a concern for a CNS infection, is actually what David put in the chat earlier, which is really meningitis. As meningitis can touch the nerves, your cranial nerves exit through your meninges, as Robbie has taught us. So that contiguous inflammation as it passes through the meninges will cause those nerves to basically become inflamed and go down. And when this started is going to be hard to tease out because headache can be a manifestation of these ear infections. So where along the course this touched the brain probably would be whenever the neurodeficits started. So if this is correct here, 6 months ago, the double vision, if that is truly when the brain was compromised in this case, I would say that this is really a chronic meningitis sort of syndrome. I'm making a leap here. I'm making a leap that this patient has a meningitis syndrome, and now our job's to figure out like what that is. So, there are acute meningitis syndromes and there are chronic meningitis syndromes. So, chronic meningitis syndromes are not due to your typical kind of typical bacterial organisms like pneumococcus, H. flu, things like this. Usually we're talking more about viruses, atypical bacterial infections, fungus. Alec or Austin presented a cocci meningitis case on the podcast recently. I think Canada would be interesting here to entertain, given, we already saw that from the ear itself. But basically, I think something more indolent is going to culture out. And my final reflection is it's very interesting how unimpressive the labs are. Like if you just ignored the history and looked at the labs, you think this person's not very sick. The brain is a protected space in terms of inflammation. So the blood works generally, unless if there's sepsis from something like pneumococcal meningitis, the blood work really won't reflect how severe the inflammation is in the brain. So in this case, when you look at the history and see that multiple nerves are down, you realize how bad things are, even though the blood work looks good. So I'm pretty worried about this patient. I think we're going to have to get the LP, as Youssef said earlier, and I'll pass it to you, Youssef.
Yeah, thank you, Andrew. And as if we hear that most of the labs are basically normal, is that right? Okay, thank you.
Yes.
So I think similar to what Andrew is saying, I think if we also use this patient has possible infections in the past, but now with persistence of a possible infection, and here we can use like the wrong bug, wrong drug source control schema. So on the wrong bug, you can on the wrong bug and wrong drug, you want to think about what organisms are not treated with routine antibiotics. So for example, under bacterial organisms, the question is which ones are not treated with like augmentin. And this is where I'm thinking about like slow growing organisms. Think like actinomyces or mycobacterial organisms that don't typically grow in that area, but like under bacteria, I would think of actinomyces and nocardia are big ones that are not just covered by routine antibiotics. And then fungal, like Andrew already mentioned, the dimorphic fungi as well. And then the non-dimorphic fungi are the mucor, etc. But this is typically more hyperacute. But I can imagine where like a source control issue where this patient was on fluconazole, but there's like a collection there. And because immune deficiency, even though we think about it as like qualitative or like in terms of like the components of the immune system, you can also have like a structural immune deficiency. So if you had an infection that caused like an abscess or a tract, then that's a form of immune deficiency as well, because that will not resolve until you resolve that structural immune deficiency. So so what I would do next is like Andrew's saying is like maybe get like better picture uh with dedicated images that target both the brain and the sinus tracts and the NT tracts, and then take it from there. Isab, how many aliquots do we have left?
3 more aliquots.
Okay, can't wait.
Okay. So a patient was discharged from the ED for to be worked out outpatient. But then he presents 10 days later to the ED with 3 days of sudden vision loss. So 4 days ago, he covered his left eye when he was going to sleep. And upon awakening, he was not able to open his eyes and everything was dark. So he planned to see ophthalmology, but he was not able to because of insurance. So they referred him to the ED. And our presentation, he had normal pressure of the eye, but there was mild proptosis of the left eye, minimally reactive pupil, and complete restriction of the external ocular movement on the left. And neurology was consulted. And cranial nerve exam showed afferent pupillary defect on the left eye and unable to move or see from the left eye. There was left facial droop with forehead involvement. There was no, the sinuses were normal, but the left ear canal was full of cerumen and no pus or necrosis. But there was narrowing of the canal and perforated tympanic membrane, and there was mild tenderness to palpation of the neck with no nuchal rigidity. Let me stop there.
Yeah, that's
Youssef, you should
awesome.
start this one.
I'm gonna pause for like 2 minutes for like breakout rooms just to see for a discussion about like where are you localizing this lesion and what do you want to do next and who you're calling and what do you want to do next. I'm just gonna pause and have the breakout rooms for like 2 minutes. Yeah, welcome back everyone. Anybody wanting to share what you all discussed? What are you worried about? What you want to do next?
Looks like we have no cameras on, Youssef. Today may be tough.
Yeah, okay. Andrew, do you want to share what we talked about?
Yeah. Our summary was that we were trying to nail down kind of an organism, which we're still thinking is kind of the culprit of what's going on in an infection. If risk factors can kind of guide us. So we were talking about not only the A1C being close to 10%, but also the steroid use recently, putting this patient at risk also for particularly fungal infections like Candida and mucormycosis. So I think for next steps, we definitely need to get some better imaging for ENT. Although we should note that this patient's CT was remote, so probably in real life we would be getting a repeat CT with IV contrast, and because we're seeing compressive effects on the eye in the form of this diplopia now actually could very well be misalignment now from how swollen the eye is, and it seems there's some compression on the optic nerve with the vision loss. So I think if we do a CT with IV contrast, we're going to see something back there for ENT to evaluate, and for us to get tissue from, as Yusuf was saying earlier, so that we can figure out this organism. And I have a suspicion we can talk about, Yusuf, I'll pass it to you, what like antimicrobials you would want to start empirically, but I think we're going to need to have surgery basically go into this patient to fix this process. I think if we give antimicrobials with all the mass effect that's going on, I don't know if we'd be able to save this patient from really their life. So what do you think we should give them in the meantime, though, Yusuf?
Yeah, similar to you, Andrew. I think a good like oral exam would be good here as well to look for like necrosis at the top of the roof of the mouth, for example, or areas there. We were worried about like fungal organisms. I think we were trying to think like what could we be missing, and I think the evidence here that the steroids did not help and the patient actually got worse, is telling us, oh, maybe this is like, do we use not enough immune suppression, or was this patient have an infection? And I think we're leaning towards an infection here. So I think the biggest question is what kind of infection is it? And it seems to be rapidly progressive, and it seems to have like to be crossing like tissue planes, the ear, the eyes, etc. So we're really thinking about here you consider like actinomyces or fungal organisms, and I think we might have this might be a case where you might do amphotericin, Andrew, like really soon, like either right after the imaging or before. And I think this patient needs source control ASAP. So I'm also calling my ENT colleagues to do like surgery or to like visualization of those tracts. So scary case. I'm nervous, but Asif, can't wait to hear more. And hopefully no amoeba. I think this seems to be to acute on chronic, and I think of amoeba as usually very hyperacute. So hopefully no amoeba as well.
All right. Very great discussion, everyone. The lab, we have some labs. WBC was 10.9 with 92% of neutrophils, hemoglobin 10.2, platelets 539. BMP was within the normal range, but ESR was elevated more than 140. CRP was 104, and lumbar puncture was done. CSF showed 20 cells, 73% lymphocytes, 2 RBCs, glucose of 101. CSF to serum ratio was 48%, and protein of 88. CSF was negative for cryptococcal antigen. And they also did urine histoplasma antigen, which was negative, and also negative serum aspergillus antigen. Serum 1,3 beta glucan test, the fungitel was positive at 101, which was elevated. And we also have the CSF fungal culture was done. But before that, they started him on broad spectrum antibiotics and amphotericin, and the CSF fungal culture was after amphotericin was started, and it was negative. ENT tried to get tissue for biopsy or culture, but was not able to, and they did imaging. I have like 3 images if you'd like, I can share. They did
That'd be
MRI.
awesome.
Okay. Um, Mm,
I'm ready for like a jump scare photo you said.
I don't know how well you can see. Let's see.
Yeah, yeah, we could see it just fine.
So this is it's not the series, so it's just one picture from the MRI. And,
Looks like some leptomeningeal thickening versus epidural kind of compression there, Youssef, something like that. And the bone also is lighting up, like osteomyelitis, perhaps.
Right.
And then there's one more, Youssef. These are great photos.
yes,
Thank you.
that's this is the MRV.
Wow. Where's Hemoon? Hemoon called it. Wow, I feel like this is like a textbook case, Youssef.
Yeah. Do you want to go for describe the manager or what you're thinking?
Yeah, yeah. So there's some sort of, venous that you could see the caliber of those venous vessels with the contrast are not like smooth. There's like tapering. So there's something inside of the venous vessels that's kind of causing it to be narrowed. So in the context of a suspected infection, we're thinking that's a reactive kind of venous sinus thrombosis, just like in the gut, how you can have a reactive portal vein thrombosis in the setting of like an IBD flare or appendicitis. It's the same exact phenomenon. So it seems like they have some sort of reactive clot in the brain, along with probably chronic osteo and chronic leptomeningeal findings or this epidural abscess sort of finding. So it's all stuff that we were worried about originally. So we need to talk to our neurosurgeon and ENT friends to collaborate to figure out how to get source control on this issue. And then I can pass it to you, Yusuf, for the lymphocytic pleocytosis, because I think that, of course, also lines up with the kind of tempo of chronic meningitis we were thinking of. And I think we're very, very close with the fungitel here.
Yeah. I think like you said, we're in the area of like this is probably infectious, and the question is what kind of infection it is. And to try to stratify it, you can and the lymphocytic vasculitis just adds to that, I think, at this point, because we're not concerned about like we're less concerned about a vasculitis or lymphoma. We're more worried about like an invasive infection. And the question is, now that we know it's an infection that's causing lymphocytic vasculitis, we already thought it was probably going to be like a fungal organism. The question is which one. Uh, I think one way to stratify it is, do we think this is hyperacute or this is subacute? Because if this is hyperacute, you typically think of like mucor or aspergillus, while with subacute, you want to think of like the bacteria like actinomyces or nocardia or blastomycosis. And these are all like or infections that can cross tissue planes of the face. So I think getting tissue from everywhere and trying to sample it and starting broad and trying to get a surgeon to see if they can access anything. Uh, in terms of PJP, in terms of, sorry, beta D glucan and what to think of that, I always try to pull up my notes. I'm going to pull up my notes, but for beta D glucan, if it is positive, it is not specific. But if it is negative, then you can try to rule out blasto, crypto, or zygomites. So usually in this case, it is mildly positive, so we can rule out it's less likely to be blastomycosis, for example, because blasto does not cause a beta D glucan. Crypto, which we were not was not high on our differential, but that's likely. But still, like all the fungal organisms could be at play here. So I think having amphotericin on board is the right move, and I think the next step is see if they're eligible for surgery. And I said, does the next iPod reveal a diagnosis or not yet?
Yes, it does.
Okay, okay. Let me just create a poll so people can vote. We have maybe 33% voting for like a bacteria, like nocardia or actino. We have almost 50% voting for mucor and aspergillus, and someone voting for non-infectious. So back to you, Isab. Oh, I think
Oh,
you're on mute. Sorry.
sorry, is it?
Sorry, I
The
forgot.
suspense.
Sorry. So I'll go with the impression of the MRI first. So it was skull-base osteomyelitis with internal auditory canal involvement, left mastoid effusion, and increased enhancement of the left orbital apex and optic nerve. The spinal MRI impression was heterogeneous enhancement of the C2 to C4 vertebral bodies, and the MRV showed partial thrombosis of the left sigmoid sinus and jugular bulb. So the final diagnosis was malignant otitis externa, complicated by cervical and skull-base osteomyelitis, osteomyositis, sigmoid sinus, and internal jugular vein thrombosis with a suspicion of fungal infection due to aspergillus. The patient had the positive fungal culture from the left ear a year ago that was not further evaluated, so that was the suspicion of the infection. And so the patient was treated with amphotericin, but because the patient presented late and delay in diagnosis, it was deemed to be a very poor prognosis. He was sent home with voriconazole therapy.
Wow, Isab, what a fascinating case.
Yeah, it's very
Yes.
interesting.
Thank you for sharing. And were you able to see this patient or not really?
No,
Okay,
I
okay.
wish I did, but yeah, I was not able to.
Okay. Andrew, any reflections?
No, I'm still thinking of, where along this course the patient could have been intercepted earlier with a high enough threshold to basically perform higher sensitivity imaging to catch this sooner. Because the CT was done when the patient was already suffering consequences, neurologic consequences, but it doesn't seem to have been a point where there was either these mass lesions or the frank osteomyelitis. We don't know if that CT scan had contrast, which is really needed to greatly enhance the sensitivity for osteomyelitis, although we know that even CT is not perfect for the diagnosis of osteomyelitis. You really need MRI. So I'm just wondering if this is a hard case to catch on the earlier side. But if you take the neuro symptoms seriously, then perhaps it could get you there earlier. Because again, if you look at all the objective data, ignoring the repeat CRP and repeat ESR, this guy was discharged from the ED with normal vital signs and a white blood cell count of barely 11, which could tip you off, but honestly, it's really not super impressive. So, taking the history seriously is probably the first thing that could have got this patient to a diagnosis earlier. But I could see how there were many context traps that got this patient a delay in diagnosis.
Yeah, thank you. I think the other thing is that we're really good at diagnosing like rapid infections, but I think it's harder for us to diagnose slow growing organisms until it became fast and it became like easier to spot. But before that, it was really slow, so it was harder to like manage. So thank you so much for sharing. So back to you, Kritika, for the teaching points.
Amazing case, Azeb, and thank you, Yusuf and Andrew, for the great discussion. So today we had a patient who was 58-year-old and had a headache for 6 months. So Yusuf mentioned in screening, we used the mnemonic SNO, which is systemic symptoms like fever and other systemic symptoms and any focal neurological deficits, any onset of headache above 50 years of age, and any raised intracranial tension are all sinister signs. And this patient had diplopia. So we need to first rule out if it is a uniocular or binocular diplopia. And we have to decide whether it is a defect in alignment or any optic tract issue. And for the same, Yusuf mentioned that we need to check by closing one eye And if the diplopia is resolving, then it is most likely an alignment issue. And here we wanted to rule out whether the site of involvement was the eye, which was the muscles, the junction, or the nerve. And we had a CT for this patient, which was unremarkable. But to rule out any stroke, we needed an MRI. And we also had a suspicion of giant cell arteritis. And Yusuf mentioned that very rarely it can also cause posterior circulation stroke. And this patient also had dysphagia, which could be oropharyngeal or it could be a esophageal cause. That again could be a structural or a functional one. And Yusuf also mentioned that it could be part of a muscle issue like polymyositis or due to nerves. And this patient had uncontrolled diabetes with a HbA1c of 10, so which increases the risk of candida and mucormycosis. And another possibility that was thought is chronic meningitis syndrome. And Andrew mentioned that it is most likely caused by some viruses, atypical bacteria, and fungus like candida. And Yusuf mentioned this concept of wrong drug and wrong bug. That is, probably we are covering for organisms which are not treated with the routine antibiotics, which could be actinomyces, nocardia, tubercular infections, any dimorphic or non-dimorphic fungi. And depending on the presentation, we can also rule out the organisms. That is, if the presentation is hyperacute, it could be mucor or aspergillus. And generally, subacute presentations are seen with actinomyces and nocardia. And also in this patient, we saw that beta-D-glucan was positive. Yusuf mentioned that it has a high negative predictive value for blastomycosis. Thank you.
Thank you so much for the amazing case. And yeah, Isaac, can't wait to read more. Thank you for sharing. Can't wait for your next presentation. This was awesome. And if anybody wants to present the case, you can sign up on the website. So hope you all have a great Monday.
Yeah, great case. Take care,
Yeah.
everybody.
Bye.